Hello, everybody. And for this chapter, we are going to be discussing neurocognitive disorders, as they refer to abnormal psychology. So, as an overview, you might be asking yourself, why are the neurocognitive disorders discussed in abnormal psychology? And the reason for that would be that if you look at that second bullet, some cause symptoms that look like other psychological disorders. So you might have an individual who had a stroke or something like that, and therefore ended up with neurocognitive damage. And due to that damage, depending on where it is in the brain, could cause symptoms that look very much like some of the symptoms that we've been discussing with our psychological disorders. It says their brain damage can cause changes in behavior and mood as well, and depression and or anxiety often accompanies these diagnoses. So you can imagine that if you did have some kind of a brain injury and it dramatically changes the way that you can think or the way that you're acting, changes your lifestyle, that definitely depression and anxiety could follow from that. Okay, so that's why it is put in here, and the DSM lists it under psychopathological conditions. So let's look at some brain impairment. The old category of delirium, dementia, and amnestic, and other cognitive disorders are now all called neurocognitive disorders. Okay, so new subsections based on severity are delirium, major and mild neurocognitive disorder. Okay, and we'll talk about each one of these as it refers to dementia and amnesia and other cognitive disorders. Okay, so damage or destruction of brain tissue may involve a wide range of outcomes depending on where in the brain it happens, right? The premorbid competence, which means the ability in this individual, if they were somebody who were highly educated and that kind of thing, they might have a better prospect for recovery. Personality and individual characteristics, somebody who is optimistic, somebody who sees things as more of a challenge versus stressors, those are going to be key components, and individuals' life situation. So here we can talk about social support, family support. If they have that, there's going to be a better outcome as well, right? We can look at diffuse versus focal damage. The idea being here is that a stroke might affect a very focal point in the brain, a very specific place in the brain, while as oxygen deprivation or toxins can create damage that's diffuse throughout the brain. Another thing that we'll look at is where this damage is located. Let's say left hemisphere. Left hemisphere is big for speech production. It is big for speech interpretation. That's where most people's language centers are. So we would look at that. And then the right hemisphere is more specific for reasoning and spatial relations. So we can anticipate that if we see brain damage in the right hemisphere, that those characteristics would be affected. And here are some of the brain structures, just in case later on in the chapter we throw one of these terms out, that you'll have at least a little bit of a basis for you. When you look at we'll start right there at 12 o'clock, motor strip, that's going to be in the frontal lobe, and that is the motor areas of the brain. Okay, the sensory strip, that's parietal lobe, that's a semiosensory cortex. Then you have the parietal lobe listed. The thalamus is the switching station. the occipital lobe for vision, cerebellum for movement, medulla for keeping us alive, breathing, respiration, that kind of thing. Sleep centers, reticular formation runs through this area. Also, arousal functions. The temporal lobe, specific for audition. Hypothalamus, just below the thalamus, that's where our basic drives are for hunger, thirst, so on. Frontal lobe, critical thinking. And then you have limbic system. That is all about the emotions there. And then the corpus callosum, which is the connection between the two hemispheres. And that's going to be white matter, these axons that connect the two hemispheres together. Okay? And it just gives you a brief overview of some of the brain areas viewed with a mid-sagittal cut there. Okay. Is there an interaction between the neurocognitive nature and psychopathology? Well, yeah, there's a close link between these two conditions. Psychological disorder not necessarily and completely explained by patient's brain damage. Okay, so there does seem to be an interaction. Oftentimes it's not manifested in the same exact way, but if we see the depression or the anxiety or something like that, we might be treating it in a very similar fashion, knowing though that it's due to this brain abnormality. Okay, and then you have delirium. Okay, this is confusion, disturbed concentration, and cognitive dysfunction. Treated as a distinct disorder. Can occur in person of any age, though the elderly and children are particularly high risk, and may result from drug intoxication or withdrawal. Can also occur due to head injury or infection. Okay, so the overall confusion, disturbed concentration, treated as its own disorder and may result from head injury or infection, etc. The delirium is oftentimes reversible and most often treated by medications, environmental manipulations, and family support. Okay, what about major neurocognitive disorder? This involves marked deficits in cognitive abilities, slow onset in older adults. Category includes at least 50 different disorders. So here's where you have things like meningitis, Parkinson's disease, and these can be due to multiple causes, with degenerative brain disease as the most common. Not the only, but degenerative disease as the most common. And we'll discuss many of these neurocognitive disorders a little bit later. But if you look at them here, percentage of people of all cases, so major neurocognitive disorder is primarily due to Alzheimer's disease at 56% there, and then it goes down dramatically. We see about 15% due to strokes, and then there's multiple causes. Once we get down to Parkinson's disease, about 8%, brain injury 4%. Okay, what about Parkinson's disease? This is the second most common neurodegenerative disorder. Remember, slowly occurs over time. Again, with these, etiology is not entirely known. There's no cure. Okay, so it just continues to get worse after the diagnosis. Characterized by tremors or rigid movements, primarily caused by loss of dopamine neurons. And I can elaborate a little bit there. What we're looking at here is the dopamine neurons in the substantia nigra are about 90% depleted by the time the individual sees the first signs of Parkinson's disease, those first tremors or rigid movements. So that means that it's going to be really, really hard. to try to increase the amount of dopamine. And those dopamine neurons then send their action to the basal ganglia, where the motor units are. They're the motor systems in the brain, and that's what moves our arms and legs and so on. But it's really because of the depletion of the dopamine in the substantia nigra. So what they're doing is they try to stimulate those neurons. They try to help them produce as much dopamine as possible. We'll put these individuals will take medications like L-Dopa, which introduces more dopamine into the area, and it does help for sometimes for a short period of time. But what you have to remember is that 90% of the dopamine neurons are depleted by this time. So it's really an uphill battle. And it says about 25 to 40%. So that's pretty high of these Parkinson's individuals who show signs of cognitive impairment as well. There's also Huntington's disease, which is a rare degenerative disorder. It is chronic, progressive, just like the others that we talked about. Patients usually develop dementia, okay, and death occurs 10 to 20 years post-symptom onset. So it's very much a devastating disease. Alzheimer's, again, progressive and fatal neurodegenerative disorder. Most common cause of dementia, hands down, associated with characteristic dementia syndrome, and usually has a slow start but progressively gets worse over time, and normally terminates in delirium and death. Here this shows you the progression. Onset after the age of 45, very, very rare to see any symptoms before that time. We do start seeing multiple cognitive deficits. Drugs alleviate the symptoms a little bit, just like we were talking with Parkinson's disease, but deterioration persists, and then the patient is bedridden, and then finally death from pneumonia, respiratory or cardiac problems. Some risk factors for you on Alzheimer's. Advanced age. We see this a lot, that people that are living for many years into their 90s, 100s, they're probably going to show signs of Alzheimer's disease. Okay. Gender, a little bit worse in females. Current smokers, lower socioeconomic status, individuals who have had head trauma, and then also obesity and diabetes are some risk factors. Biological factors, I don't want to go into a lot of detail on these. I would never ask you in a quiz midterm or anything like that the exact gene that we're looking at. Just know that there appears to be a genetic component to Alzheimer's. And then some other biological factors here. We're looking at brain atrophy, which is the death of neurons, right? So it's if a muscle becomes atrophied, it becomes much smaller, less active, less able to work or function. Same with the brain. You have the amyloid plaques. You have the neurofibrillary tangles. These are things that we can actually see in the brain. Unfortunately, these things are shown after the symptoms have already occurred, so it's very hard for us to develop methods of avoiding the amyloid plaques or avoiding the neurofibrillary tangles. So we don't know exactly why they occur, but we do know that once they do occur, that they interrupt with the normal functioning of the neurons. Also, the reduced acetylcholine, this has become key in the research right now, to where they are providing medication that increases acetylcholine to these individuals that have early symptoms of Alzheimer's. So the treatment, the disease course, we know that it is going to get worse. It's going to be progressive, so we can plan for that. It causes destruction of cells that make neurotransmitters important for memory. So it's also hitting the hippocampus, which is a specific area for long-term potentiation or taking short-term memory and putting into long-term memory. Drug treatments include cholinesterase inhibitors. So those are going to be enzymes that break down acetylcholine. If you take out those enzymes, then you're going to provide more acetylcholine, and that's good. Drugs that help stop acetylcholine from being broken down. Okay. So you want to introduce an acetylcholine agonist. Agonists increase the amount of drug in that area. So these are going to be increasing the amount of acetylcholine. Here is your e-lecture topic item. Please fill that out and submit it with your discussion thread. Okay, let's talk about some other neurocognitive disorders. Causes of impairment is usually very clear, unlike most other DSM-5 disorders. These can include HIV infection or vascular dementia, such as a stroke. Amnestic disorder. Okay, strikingly disturbed short-term memory. So they can't hold short-term memories. Brain damage from injury, tumor, stroke is what we see here, and there are various treatment techniques. Just kind of depends on what we're looking at. If it's a stroke, then they might introduce some kind of a very strong anticoagulant drug that will open up areas, because if there is a stroke, there's a clot there, the neurons can't function, they're not gaining nutrients, they're not gaining oxygen. Traumatic brain injury. This affects about 2 million people annually in the United States. Can be due to falls or car accidents, and there's here's what we're looking at: damage to the brain, causing some of these neurocognitive disorders. Head injuries, they result in retrograde amnesia. What that means is that the inability to identify memories that have happened in the past. Anterograde amnesia, and that is the inability to form new memories. So both of those can occur in head injuries, as well as personality changes. Okay, concussions and closed head brain injuries. So you think to yourself, it makes sense that for somebody who had an aneurysm, somebody who had a stroke, those are closed head injuries, or those are head injuries that are causing a lot of damage because of the neurons and so on that they're affecting. But there are also disorders that are due to closed brain injuries, like concussions that occur in sports. And like this bullet here says, small hits matter. Injured brain takes several weeks to recover. So even though an individual has a concussion and they kind of shake it off and they don't think that there's really any long-lasting effects, but there could be some damage there. So treatment for head injury, prompt treatment post-injury is important. Remove the pressure on the brain. You have to remember that if the skull is struck like that, it will bruise, just like we bruise in other areas of our body. The difference here is that the skull cannot expand, and so this pressure builds up in the brain. We have immediate and long-term re-education and rehabilitation, and then treatment teams often involve a wide variety of health professionals to help these individuals, because there can be, it's kind of an eclectic, what they call an eclectic approach, where you're looking at neurologists, you're looking at brainwave activity, you're looking at maybe doing a PET scan or an EEG, trying to identify that the brain is acting in a normal manner. Okay, and that's it for this chapter. Thank you.